Hi, I'm Loressa Klassen. I'm one of the nurses in the MS Clinic. I work in Winnipeg, Manitoba, and I'm here today to talk with a couple of ladies who've just been diagnosed with MS. I imagine you have a lot of questions to ask me about this new diagnosis. Why don't we get right into that and you tell me what's on your mind?
My first question, with being recently diagnosed, I'm just wondering what my next steps are.
With a new diagnosis of MS, it is very important to make sure that you have access to as many resources as you can. I believe that, there are many community neurologists, and you may have already seen one, to have your MRI done, that are very good at being able to work with people and see people all the time with MS. But there is a different level of expertise that's available through going to a specialty clinic that does specialize in looking after individuals with MS. So I know that here in Saskatoon, you have City Hospital, and there you have a dedicated MS clinic. You have a nurse and a physiatrist. You have other resources within that hospital setting, like referrals to occupational therapy and physiotherapy. And so what I would recommend for a person who's newly diagnosed is to seek one of those referrals either through your family doctor and or through the neurologist who made the diagnosis of your MS.
So I just was at my doctor's. How do I know what type of MS I have?
There are several different clinical courses of MS. It's not the kind of thing that you can say, look at your MRI and determine what kind of MS you have based on an MRI result. We determine what type of MS you have based on the type of symptoms that you've been experiencing and the pattern of the symptoms. So for instance, the most common kind of MS is actually called relapsing remitting MS. And in that form of MS, about 80% of people will experience at the onset some form of neurologic symptom, and it will come on, last for a period of time, typically 4 to 6 weeks, and then the symptoms will improve or go away. We call that a remission. And between the time of that event, the first event, and then a subsequent event, there can be many months or even years between each event. So relapsing remitting MS is a common form, but there are other forms, such as progressive MS. In that setting, people will often develop symptoms that never go away. So right from the onset, you will have symptoms that come and stay. They may worsen over a period of time, but we will talk to you about your history of symptoms. And so it is really based on the information that you come in and give us about how the symptoms came on and what they did over time that we're going to be able to determine what kind of MS you have. And it is really important to determine that early on because we do have so many treatment options and strategies that we can use depending on the type of MS. It may be a first event, clinically isolated syndrome. It may be relapsing remitting MS, the most common form. It may be primary progressive MS. It may be a unique form of MS called neuromyelitis optica or Devick's disease. So there are many different forms. Once we determine what kind of MS you have based on your history of symptoms, then we'll know what to do in terms of treatment.
So because this diagnosis is so new to me, I'm just kind of trying to find more information, and I'm wondering if MS is contagious or hereditary, or if it is fatal.
That's a good question. MS is what we call a chronic disease. That means that it's a disease that you're going to live with over your lifetime. But having said that, MS is not an illness that should, for the most part, shorten your lifetime. It is not an illness that's going to contribute to an early death or anything like that. It may be, in some families, hereditary. There is what we call some loaded families. So there may be families that have more than one family member that have MS. And in these situations, there may be some slight risk above the general population for other family members within that family to have maybe more susceptibility to developing MS. But typically, MS is not a normal pattern of hereditary kind of transmission that we see in other illnesses. So, it is something that I wouldn't worry about for now at this early point in your diagnosis, but certainly if you do have a history of other family members, you could talk with your doctor about possibly being referred to a genetic specialist or someone that you could speak to, if you were planning a family.
Therapies are available to me.
It depends on what type of MS you have as to which therapies are available. We do have a category of medications called disease-modifying therapies. These are 4 injectable therapies that are available and have been shown to be useful in reducing relapses in people who have relapsing remitting MS. And one of them is actually approved for use in people who have secondary progressive MS, which is a form of relapsing remitting MS. In that setting where you have secondary progressive MS and have relapses, there still may be some use to trying these disease-modifying therapies, particularly one of them called beta-seron. There are 2 different types of medications. One of the types is called interferons. There's Avonex and Rebif and beta-seron. And these are medications, as I say, that are all given by injections. They're all given with different dosing schedules and different sort of daily to even weekly dosing regimes. So it really becomes important to learn about the medications, see if there's a medication that actually is a better fit for you based on your health history. What other sort of medical problems do you have? Do you have anything significant that we would need to consider when you're looking at a medication and which one would be best for you to use? There are often recommendations from your physician about using a medication for treating your MS. And in that condition, I strongly encourage people to listen to what the doctor has to say. They've often considered many of those, that sort of background information about your health when they're making a determination about which treatment to use. If you have progressive MS, we often focus on looking at symptom management. If you have relapses, that again is another sort of level of treatment. We would treat acute relapses differently. So it's really going to depend on what type of MS you have, what your current symptoms are, as to how we approach treating it overall.
Do you have any suggestions on how a person could prevent relapses?
I'm going to start with hoping that everybody knows what a relapse is. And that's really important as you're new with this diagnosis to figure out, what's important to talk to your doctor about and what should I worry about, what don't I worry about. A relapse is actually defined as the onset of a new symptom or the occurrence of or reoccurrence of or worsening of existing symptoms that occur when there's no fever or flu or infection present. They will last, the symptoms, at least 24 to 48 hours. And depending on how severe the symptoms are will depend on what we should do about them. You can actually have worsening of MS symptoms with other precipitating kinds of influences, like say a fever or an infection. People will often call and say, gee, I'm really worried. My MS is really bad right now. I'm having a hard time walking. They sound terrible. They sound very congested. I say, it sounds like you've got a really bad cold. Oh, well, actually, I've got pneumonia, but I'm not worried about that. I'm more worried about my MS. I'm having a tough time walking and getting around. And that kind of scenario where there's something influencing the MS symptoms is actually called a pseudo-relapse. So it is a worsening of symptoms related to the influence of the infection or the fever or the flu that you have. Once you get better from the underlying infection, fever or flu, the symptoms get better, and we call that a pseudo-relapse. So the first thing that we need to do when someone comes to us worried about a relapse or having new symptoms is figure out, are we dealing with true disease activity, or is this actually a relapse or a worsening of symptoms because of some other negative influence on your health? So we need to sort that out. One of the things that often happens with people with a new diagnosis is that they can have a urinary tract infection, and you can have it without any of the typical or expected symptoms of a urinary tract infection because you've got MS and you've got these plaques in your brain, and these plaques may actually be interfering with the way your bladder works and senses impulses and experiences things, you could have an underlying infection. In our clinic in Winnipeg, when we get an onset of new symptoms or a relapse, we always say to patients, we want you to go and just make sure you don't have an underlying infection that we're not able to detect in some way. Typically that's the urine. Have a quick urinalysis done. That's just giving a urine specimen, and then they analyze it, and if there's any bacteria in that specimen, then we know that the symptoms you've got now are probably because of the infection and not true disease activity. If the urine is clear, no signs of any infection, then very likely we're dealing with an MS event, actually disease, inflammation in the brain. So in that setting, we now have to figure out what we're going to do to treat it. You can use the medications that I talked about earlier, the beta-seron, Rebif, Avonex, Copaxone. These are medications that have medical evidence through clinical trials that show that they reduce relapses by about a third. So they're not going to take away all relapses, but they are absolutely going to be helpful in reducing the number of relapses that a person experiences. And so we'd also look at asking you about your medication. So you've got a relapse. Are you taking any therapy for your MS right now? What is it you're taking? Have you been regular with the dosing of the medication, or have you, interrupted the dosing or stopped the medication for some reason? So I think that by adhering to your treatment, making a commitment to take treatment on a regular basis is probably one of the most important things you can do to try to prevent a relapse.
What are common symptoms I might expect?
Symptoms are highly variable and very individual from one person to the next, and even from one relapse to the next. People can experience vastly different things. Some of the more common things that you can expect, you might experience with this diagnosis, are things like numbness or tingling. Fatigue. Fatigue with MS can be a very difficult symptom. It's kind of one of those invisible symptoms, People can't always see that you're fatigued, but it's the kind of fatigue, it's not like just being a little bit tired and, sort of needing to have a little bit of a nap and waking up refreshed. It's kind of the fatigue that it's like a wall of fatigue. It just hits you, and, it can really, really impact the way you carry out daily activities if you're one of the people who suffers from fatigue with their MS. Some individuals with MS may experience pain. People with MS can have pain for other reasons as well. And so with a symptom like pain, it's really important to try to define the character of the pain. Where is the pain? Do you experience it every day? Is it there all the time, or does it come and go? What's the quality or character of the pain? Is it sharp? Is it electric? Is it shooting? Is it tightness? Is it burning? Those are the kinds of descriptions that we often find patients give us associated with pain that's related to nerve pain. But you may have pain from some changes perhaps in your walking that occurred. It can happen that when we have a little bit of weakness in one leg, you put a little bit more demands on the other leg and the other hip and the other joints, and it's sort of carrying the load of both legs, and doing, having alterations in your walking related to MS can cause pain, but that pain will feel different from pain that's related to nerve pain. And it's important to distinguish what the pain is like so we know what kind of treatment might be effective. You can actually have changes with your vision. It may be blurred vision. It may be a change like double vision. There's many, many things that may happen. They don't happen to everybody. Some people have bladder symptoms like urinary urgency and frequency, maybe difficulty fully emptying the bladder. You may experience infections because of that, and the infections may be silent, so they're not always easy to detect. I think what's important when you're looking at symptoms is trying to decide how much does this symptom impact my day-to-day living. You know, am I really finding that I'm unable to do things because of these symptoms? Am I not enjoying life as much because of these symptoms? And when there is a situation like that, these are the kinds of symptoms then that you want to bring to the attention of your physician. If you've got pain and it happened maybe once a month and it's kind of fleeting and it's not something that happens on a regular basis, you're not very likely to need to take a medication for that. But if you've got pain that's happening 4 days out of 7 and it's really starting to kind of wear on you, chronic pain can be a difficult thing, then that's something you want to talk about. And at that point, it might be reasonable to start a medication. And typically you need to take these things every day in order for them to work. So, you know, it's going to really be important to kind of, some people like to diarize their symptoms, you know, jot down little notes, what's been happening. Some things are going to come and go, but when things come and stay, then those are important to talk about.
I'm just wondering if I should see my physician every time I experience new or reoccurring symptoms.
Again, I think that when the symptoms are having an impact on your day-to-day activities, it would be important to let your doctor know. Now, the first person you may want to speak with about that may in fact be your family doctor or general practitioner. Your family doctor can assess and see whether there are any other reasons for those symptoms or those changes or that worsening. If in fact there isn't anything else influencing your symptoms, your family doctor can absolutely make a referral if needed back to the clinic, and or if you're already a patient at the clinic, you can call and say, you know, this is what's happening. It never hurts to call. You know, the clinic does have a nurse, and I'm not sure how the time frame is in terms of returning calls for that particular nurse, but typically, you know, we do try to get back to people when you call us, leave us a little bit of information about why you're calling, and you know, then we'll phone you and we'll discuss with you, is it a brand new symptom or is it an existing symptom? How is it worse? And then really we're going to what we call triage that call. Together we're going to make a determination about what we need to do about that symptom, if anything, at the time.
Okay, my main symptom right now is fatigue. What would you suggest that I do to improve fatigue?
Firstly, I would look at making sure that you optimize your health overall. There are many things that can contribute to fatigue that we can actually do something about. It might be a good idea to check with your family doctor to make sure that all your other blood work is normal. You know, is my hemoglobin normal? Have you done a complete blood count with my last physical? And was my hemoglobin adequate? Hemoglobin carries oxygen and glucose to all the cells in our body. And if the hemoglobin is low, it can cause you to feel really tired. Is my iron level normal? Often a family doctor will overlook that in just a general assessment. So checking to see, you know, what's your ferritin level? Is it 40 or above? The levels typically range anywhere from 16 to 400, and individuals who have a level under 40 may actually be experiencing fatigue from low iron, and that's an easy thing to replace by adding an iron supplement to your diet. So you'd want to ask about that. As most of our patients are women, and I mean we have 3 women to 1 man diagnosed with MS, women do have a higher incidence of thyroid irregularities, and so it is important to check your thyroid. If your thyroid is underactive, you actually may have tiredness related to that. So once all those things are optimized, then you can look at lifestyle. How am I sleeping? Am I tired because I'm not sleeping very well? Is the quality of my sleep adequate? So are there things that you can do to improve your quality of sleep? Are you not sleeping well because you're up to the washroom, you know, more than 1 time a night, which may be, again, a symptom of your MS, but something that we can look at approaching and trying to manage to improve that outcome so that you do get better quality of sleep. Are you not sleeping because of pain or other influences? So we can look at all of that. Exercise is a really important component. People who exercise more actually do have better quality of sleep, and we do encourage people to exercise. When some people exercise with MS, they actually can feel like their MS symptoms may be worse. They may feel that they get a little bit of worsening of numbness or tingling, or some of those underlying baseline symptoms that only seem to come out and bother you when you're really tired, or you're overheated, or you're in a hot tub or a hot environment. That's something that is pretty common, and so we do encourage people to exercise, and when those symptoms happen, just cool down a little bit. Those symptoms will improve with a cool down, and so they shouldn't prevent you from exercising. Exercising itself can't make your MS worse, even though in some settings it may feel like it's making the symptoms a little bit worse. You just need to find that balance between exercise and rest, and that will sort that out. But so, having done all of that, if you're still experiencing fatigue, then we may actually look to recommending a medication. And we do have a couple of medications that have been proven to be useful in MS fatigue. In our province, we use a medication called amitriptyline. It's actually an antiviral medication, so it was originally used, pardon me, it was originally used for reasons other than treating MS fatigue, but it was found to be helpful in about 50% of people who try it. And it's a quick trial. You can ask for the prescription. You can try the medication. You take it in the morning. You may repeat the dose sometimes at noon, depending on your discussion with your doctor and your instructions. And you're going to know within a couple of weeks whether that medication is going to work or not for your fatigue. Sometimes people phone me and they say, you know what, this amantadine isn't working, I'm going to stop it. And then they'll phone me back a little later and say, you know what, it was doing something. It can be a subtle kind of change that's not so easy to detect. But if amantadine doesn't seem to be helpful enough in reducing your fatigue, we can always go on to try another medication called Allertec. That too is a prescription medication. It's used very similar in a similar way to amantadine. You take it in the morning. Sometimes you can repeat the dose throughout the day. But with either of these medications, you have to be careful not to take them too late in the day, because if you take them in the afternoon, say later than 2 p.m., they may actually cause you to have trouble sleeping. And so you get into that vicious circle where, again, you've got other factors that are contributing to your tiredness.
I'm just wondering if I should look into alternative and complementary therapies and treatments.
Might be a good thing just for me to be clear in terms of alternative and complementary treatments. Typically, when we talk about alternative treatments, we mean treatments that are going to replace standard medical recommendations. So instead of using a prescription medication to treat your illness, you're going to use maybe a herbal medication, something from a naturopath, something to actually replace standard medical treatment. When we're talking about complementary therapy, we mean using things that are going to enhance our medical treatment. So these are typically things that you'll do that are in conjunction with your prescription medications. So looking at things like it may be acupuncture, it may be massage, it may be the use of some vitamin supplements, it may be your exercise routine, or something that you do for yourself that actually improves or enhances your lifestyle and your quality of life. And I think those things are all doable with MS and actually can be quite helpful for some individuals. What's important is just to let your physician know when you're seeing them in the visit that you are in fact doing these other things and how you're finding they help you. But certainly, by all means, it is important to do whatever makes you feel good, makes it easier for you to live with those symptoms on a day-to-day basis. And we can say that perhaps alternative treatment, that's our alternative therapy, looking at something with a naturopath, say, instead of our medical prescription, is maybe not something that we're in full agreement with. But the thing about working with you and trying to establish kind of a relationship with you and treat you and provide care for you over the years is that we need to respect the decisions that you make and recognize that everybody who comes to the clinic may not share our beliefs or our value system. And so there certainly may be times that, that we need to support our patients in different ways.
What therapies are available to me?
We have many therapies available right now for treating relapsing remitting MS. We have what we call our first-line medications. These are the medications that the physician is going to likely offer to you early in your diagnosis. These are all injectable therapies that we use because they've been shown to reduce relapses by about 1/3 on average, and also been shown that over many years of use, there is the potential to reduce progression of MS over time. So we have a group of medications called interferons. We have beta-seron, we have Avonex, and Rebif. These medications are similar but different in the ways that they're taken. So they're different dosing schedules and they're different dosages, and they may actually be given by different forms of injections. So typically they're given just either under the skin in the fatty areas of tissue in your stomach and your legs, or they're given into a muscle. They're all things that we teach you how to inject yourself. They have side effects, and there are certain kind of extra considerations that we have to look at when we put people on any of these treatments. There may be blood work monitoring that's required. There may be strategies that we need to use to alleviate the side effects that are primarily experienced early in the treatment. Say, for instance, with the interferons that I've mentioned, we know that they have a predictable side effect kind of profile. We know that they're going to cause, in the majority of people, in about 2/3 of people, flu-like symptoms, and that doesn't mean nausea or diarrhea or vomiting. That's more like fever and chills and aching, achy muscles, and these symptoms typically come on about 3 to 6 hours after you take the needle, and they can last, about 12 hours. So we have all kinds of strategies for how to kind of get through that early phase of the treatment when those side effects are present, because they will go away with time. But in the beginning, they're kind of a tough thing to work around, and so we start you typically at a lower dose of the medication and build the dose up over a period of time. We actually will recommend maybe taking the medication in the evening or before bed and using ibuprofen or acetaminophen or even something like Aleve to alleviate those fever and chill-like symptoms that may come on through the night. Hopefully you're going to sleep them off through the night. When you wake up in the morning, you're kind of getting back to normal. And they're only going to occur in conjunction with the injections, and they're going to get better with time. So by about the 3-month point, those side effects we expect would be very, very minimal if they're occurring at all. If they're still occurring, we may have to have a little bit more talk about whether that treatment that we picked or you picked, your doctor may have made the recommendation for you based on your other health history, or perhaps the doctor said, I've got these 4 medications, I want to tell you about them, I'd like you to make a choice. If you've made a choice and it doesn't work out, the good news is there are other medications that you can switch through to try. We have a medication called Copaxone. It's a daily injection, but it doesn't have any of the flu-like symptoms associated with it. All injections do have, and all medications do have side effects that have to be considered, and so we always look at the risk or the downside or the troublesome side of taking a medication versus the benefit side, right? And you're always weighing those two things when you're looking at a medication and which one may be best for you to consider. Those are our first-line drugs. So those are the medications that we've used now for almost 20 years. What we know about those medications is that they're safe, the pharmacare or health programs, they cover them. We're going to offer those medications early on, and if they're working, you're going to stay on that medication for a period of time, for as long as it continues to be useful for you. Do, however, have situations where those medications aren't working, and in that setting, there are some second-line medications, maybe even third-line medications that we can consider. One of them you may have heard about is called Tysabri. Now, Tysabri is an infusion every month, so every 4 weeks you have to go for an infusion. The infusion takes about an hour. It's usually given at a clinic, and it may not be the clinic where you go to receive your MS care. It may be outside of that. Tysabri actually has been shown to be very beneficial in reducing relapses, but because there are some side effects, it is not something that we offer right away to patients. So if the other medications are failing to stabilize or control your MS and you're continuing to have relapses in spite of the medication, we might say, okay, let's look at Tysabri. There is a side effect called PML, and that's an infection in the brain, and that can happen in about 1 in 500 people who go on Tysabri, and the risk of that infection increases the longer you're on the medication, and it also increases if you've come in contact with and have exposure to a certain virus called the JC virus. So right now, we're just, a blood test has just become available actually for testing for JC virus, and so I think once we can test people and determine that they don't have this virus, it's been shown that maybe your likelihood or risk of developing that brain infection from the medication would be reduced. And so maybe that might allow a little bit more wider use of that medication in the future. There's also an oral medication that's just become available called Gilenya. It is, again, shown to reduce relapses. All these medications are for use in relapsing MS, but it does have some side effects that it may slow down the heart rate. So again, it's not going to be the first thing you're going to offer, but if you're needing to sort of do something more than the standard sort of proven therapies, this may be an option. It does require some special monitoring that needs to be done when you're given the first dose, and so it may require some monitoring in the hospital for a period of 6 hours or so with the first dose. But following that, actually, people are just starting to use it in Canada. There have been a few serious side effects also that are reported, like serious infections from a virus called the herpes virus, and serious possibility that there may be more risk of some types of tumors, skin cancers. So, you really have to look at that medication in the context of how you're doing with your MS on a day-to-day basis, and how active the disease is. Really, in an more aggressive kind of situation with your illness, those things might be more appropriate to consider.
I'm just wondering if you can actually tell me my prognosis.
Prognosis is a really tough question in MS. The disease affects people so differently. It's not uncommon to have someone have a first neurologic event and have an MRI that shows plaques or demyelination that's consistent with the diagnosis of MS. Then go on to have many years of relapse-free living, like actually be free of symptoms for, 7 years till the next event, 15 years. You may be on the other side of the scale, though, and have very active disease at the onset. There are probably some small prognostic factors in terms of your MRI. Certainly, if we see a larger burden of disease at the beginning of the diagnosis, and a burden of disease just means if we look at your MRI and we measured all the lesions in your MRI, we could come up with a number, and that's the burden of disease. And if you've got a high burden of disease at the onset, we're going to be a little bit more worried about you. You're the kind of person that we're going to want to look at getting on therapy quickly. So if you've just had sort of one event and you've got an MRI that's consistent with MS and you've got quite a few lesions on that MRI, it's going to be important for you to get you on treatment right away and not wait wait for the next event to happen. We're actually probably going to look at your MRI in 3 to 6 months and see if there's any changes on that MRI, and if there is definitely continuing activity in your lesion count in the brain, we're going to recommend getting you on treatment. And we could say perhaps maybe that scenario is going to be a little bit more worrisome in the future, but we can't absolutely be sure about that. What we can't do is look at your MRI and determine with absolute certainty what your prognosis is. So we have people with relapsing remitting MS who will continue to have relapsing remitting MS over their lifetime. The natural history of the disease tells us that over time, the illness becomes less inflammatory and there are less of those relapses or flare-ups or exacerbations, attacks, those things all kind of mean the same thing. There's less of that kind of thing going on with time with the diagnosis, and that's just the evolution of the illness. We do know from studies actually that were done in Saskatchewan through City Hospital actually with one of your physicians many years ago, by following out a large group of individuals with MS over many years of disease. We do know a bit more about the evolution of the illness. That's called a cohort study, and it showed us that over time, about 15 to 20 years of illness, about 50% of people who have relapsing remitting MS will go on to develop a secondary progressive form of the illness. We're hoping that the medications that we use are impacting that outcome, and that if we use them long enough, we're going to see some changes with that natural history over time. And maybe people won't convert to secondary progressive MS as quickly, or maybe less numbers will convert. Those things are yet to be determined. The jury is still out on that. But we do hope that by treating your condition early on, that we are going to make a difference, for you 15, 20 years down the road. So it is important to be optimistic about the future as well. We have so many treatments and therapies that are currently in study around the world. I think that as we get better at treating this disease, we hopefully can make more impact and have even better outcomes with prognosis. We know that the majority of people actually don't end up using a wheelchair or depending on that. But even if you do, it's really a matter of how you look at living with your MS. Like, the MS isn't you. The MS is just something that, it's a part of you, but it isn't what should dictate, your life. It's kind of looking at the cup as being half full or half empty. And I have seen just as many people who have not had the best sort of outcomes with their disease course, and have certainly experienced progression of the disease, at a young age, that have gone on to have family while wheelchair bound and have, a very, very good and supportive system around them, have good marriages, have good quality of life, have enjoyed life. Like, these are things that are kind of within our control to some extent in terms of how we look at living with the illness as time goes on. So I think it's important just to recognize, that we can't tell you that right away. Even to diagnose it and figure out what kind of MS you have, we have to look backwards into your history of how the symptoms came on to make that determination. And the same with progression. There are some people we worry about, but the majority of people live a pretty full life with this disease and can go on to do, have many of the goals that they would have otherwise wanted to have. So I would encourage you to be hopeful for the future.
How do I get involved in studies such as clinical trials?
There are a lot of different kinds of studies actually that may be going on in your center or elsewhere in Canada. It varies from MS clinic to MS clinic in terms of what's being offered and what's available. What I would recommend is to look for some resources to see what is going on in your community or nearby. The MS Society is actually an excellent resource to do that through. They're going to be aware of what's going on in the province. You may also look to the MS clinic itself. You know, often we're doing studies that are different in nature than standard clinical trials where they're comparing or using new medications. There may be studies going on that involve collecting data about other illnesses in MS. You know, we have in our province a director who actually has an interest in epidemiology in MS. She is looking at what other illnesses are likely to occur in people with MS. Are they at risk for other medical conditions, or do they have greater predisposition to have other medical conditions occur because they have MS? You know, we're also collecting information for a database, and so it is a study, in fact. You know, we're signing people up for that, and we're asking them if we can use their information to look at some critical questions that we may want to ask about the patients that we're seeing, and how many of them may have a particular symptom or, you know, may have a particular concern. So there's a lot that you can ask about, and there may in fact be clinical trials. Those, though, are quite exclusive. You know, when they do happen, your center isn't having them because they've chosen to have them. Your medical center gets picked, and so very often a lot of clinical studies do go to larger medical centers throughout Canada, like larger MS clinics, say in Vancouver or, you know, Toronto or Ottawa. You may hear, why can't I have that here? You know, why doesn't that come to my center? Things do eventually come to us, though, if they're proven to work. And in the meantime, you know, it is important to look and see what's available in my center and what can I get involved with.
How do I best approach my family and friends with this diagnosis and change?
That's going to be a very personal decision. Some people will choose to, you know, disclose or tell people in their lives about their diagnosis early on. Other people need to chew on things for a while. You know, they need to sort of come to terms with this information personally before they're ready to sort of share it with family or friends. I think that is an individual decision. And what I would hope for is that family and friends will support you in the way that works best for you. There are resources that you may be able to access through counseling. Perhaps the MS Society can be of some assistance there in letting you know what's available in your community. Perhaps the clinic can also direct you in some way. People, you know, will choose to share these things with their employers sometimes. Other times they worry that this may change the way an employer looks at them in the workplace, and you know, the kind of quality of work or responsibilities they're given. You know, if you do choose to tell people about this, and you know, I do hope that people do share it, because I think there's a tremendous amount of advantage that you can get in terms of support, and people need to understand what's going on with you, and you know, why you may be you know, a little bit distracted, or you know, I would be distracted with a brand new diagnosis. I'd be worried. I'd be needing to talk with someone about that. But you know, you can look and see, is there, you know, do I need to talk with someone professionally? It's a tough thing to kind of face any medical kind of condition, especially in the years that the average diagnosis is made with MS, which is, you know, primarily in the ages between 20 and 40 years of age. That's, you know, when everything's kind of going on in your life and you're doing all your goal setting. So I would say just, you know, take your time to think about how you need to share that information, and be sure that you ask for help if you need it. You know, if you're struggling with things, if you're feeling really sad and different than usual, if you're noticing that you're not motivated in doing things the same way, tell someone about that. Those may be symptoms of something else. Those may be symptoms of depression or other things that you may need to actually get a bit more professional help with. I also would encourage you to think about just optimizing your health overall. We've talked a little bit about exercise. There isn't a particular diet for MS specifically, but I would recommend, looking at Canada's Food Guide, trying to eat healthy. Many of your physicians, and it is sort of a general recommendation and consensus with MS experts, that our patients should take vitamin D as a supplement. Every clinic and physician is going to have a little bit different approach to that, but generally speaking, in our clinic we recommend 2,000 international units daily for vitamin D. I'd look at calcium. Do you consistently eat 3 to 4 servings of dairy, 3 to 4 glasses of milk a day? Do you drink other types of products that may have calcium in them? Do you yogurt or cheeses? These kinds of things, if you can get them in your diet, are excellent, but if you can't, then it is important to supplement. And the reason for that is that we use treatments sometimes, say in the setting of an acute relapse or worsening, treatments like steroids. Steroids are something that we can't keep you on long term. They're not a medication that we can actually be sure makes any difference 20 years from now in terms of your overall prognosis and progression of disease. But what we do know about using them is that if you have a relapse and it's a very acute relapse and it's caused you to not be able to carry out your daily activities, so you're not able to get to work, or you're not able to look after the children, that's a pretty serious thing. We would want to consider using steroids in that setting, and that's to reduce the inflammation quicker that's occurring in the brain and just kind of bring that attack to a quicker resolution, So it's for short-term management, but the consequence of using something like steroids to treat those relapses is that over time, medications like that can cause some damage or sort of thinning of the bones. And so it's important to kind of keep your bones healthy. So that's why we recommend at this point in time the vitamin D and the calcium and optimal sort of diet. There are studies going on right now with vitamin D looking at whether you have MS, if you take vitamin D, whether or not it does have any impact on your symptoms or your disease overall. So I think they're looking at that right now in Calgary, so we should have some more information about that. We know that there was a large study in the US that looked at women that supplemented with vitamin D versus women that didn't, and they did find that there was less development of MS, like a lower number of individuals who developed MS in the group of women who supplemented with vitamin D. So all these things are quite intriguing and may mean that there's something more in terms of how it impacts the disease overall. This is an autoimmune disease, and we know that vitamin D has played a role in other autoimmune diseases like juvenile diabetes, but we don't quite have the evidence yet to say this is why you're taking it. So you're taking it for bone health. People who have MS may have changes in their mobility such that they're not able to walk. Walking is a really important thing, like making contact with the ground is something that really keeps our bones healthy. As we walk, that's actually a really good almost like a physiotherapy for our bones. So when you're not able to do that, it is really important to supplement.